Placement can be an absolute waste of time if you're not using it correctly. Today, we're going to be actually discussing how to make the most of placements. So, Abdul, let's take it away with what's even the purpose of you going into hospital, going into a clinic, sitting with a doctor, watching a doctor, going onto the ward round. What is even the purpose of all of that?
So, clinical placements are essentially a great time and a great way to get exposed to the hospital setting, the hospital environment, get the exposure of what you're going to be doing as a junior doctor once you start kind of working. And I think it's a great opportunity to get ahead. And I think a lot of medical students, and we probably did the same at some point, was like, oh, now it's an opportunity where you can perhaps not go in as regularly. You can kind of leave early, come in late, go to teaching and whatnot. But I think if you think about it, it's a great way and a safe time to actually learn the things and basically hit the shop floor running per se. So there's many elements with clinical placements. You know, you can shadow doctors, you can do ward rounds, you can follow the consultants, you can ask the silly questions, let's say, and you can start to learn things because, like it or not, as soon as you're at the F1 on that first day, you are going to be expected to do a lot of these things, which you can familiarize yourself quite early on if you're smart about it. Yeah. So there's loads of things you can do as a medical student on a clinical placement. What is one of the first things that a clinical student should be doing?
So obviously joining the ward round, that's the big one that we all taught to go on, told to go on. We're assigned to a certain specialty and told get onto the ward round. Before we just talk about the ward rounds though, it can all be a waste of time. Let's talk about, before we go on to how to make it useful, why have you had moments where it's just been a complete waste of time, you going into clinics, going into the hospital, and then you've walked away, you spent 8 hours of your time in a hospital and you're just like, I don't even know what I did. Have you had any of those moments?
Yeah, for sure. Like, it happened regularly because you're going in there in a passive mindset. You're literally there sitting, observing. You're not actively doing anything, or you didn't go in with the aim or objective, I want to do this or I want to accomplish X, Y, and Z. You went in for the sake of it, right? You know, when you're busy for the sake of it. Yeah. And I think we did that a lot when we started clinical placements, because you're excited, you're everything's new. Exactly. And then you look back and be like, what did I actually learn?
Yeah. So I personally pinpoint, you remember the time we spent at Margate? So Margate was fun. First clinical placement, we were living out, we're going into hospital, coming out. By the end of the 3-month block, I actually thought, hold on a minute, I did nothing apart from just learn how to wear shirt and trousers and go into hospital. So I do think you're right, going in with the passive mindset of I'll just hang around the doctors and I'll just somehow magically absorb their knowledge, their experience, and whatever the consultant says. Going in with that sort of mindset, you'll probably waste all of the hours, all of the time. But I do remember we then transitioned to where we had a point where we were like, all right, today we're just going to go in, listen to murmurs and just learn what murmurs sound like and then vanish. Or today we're going to go understand what it means to examine a chest, what crackles, appear as, how to interpret x-rays. So we had objectives to achieve.
So what we did differently was the same way we had a timetable and structure for revision for exams, we had a timetable of what needed to be done and achieved for clinical placements. Yeah. And then we went in with specific goals and we went and chased them. And once we did it, it might be, earlier in the day, late in the day, we did it and we kind of moved on. So we were very efficient with the time. Exactly. Let's kind of go on to what does that all mean, right? So you mentioned ward round, join in on the ward round, right? So we joined in on ward rounds, but what did we do wrong? What should we have done?
So ward round is a waste of time if you're just standing there shadowing and watching. That is probably the most passive waste of time. You're just sitting there, standing and just following along like a sheep in the background, right? So if you're doing that, you're doing it completely wrong. Rather, get involved. Ask the most junior member on the team. Why do I say most junior? I say it because you can be of maximum use to them actually, right? If you ask the F1 doctor or the F2 doctor, do you want me to get all the OBS charts for you and read out the OBS when we're on the ward round? Or do you want me to grab the ECGs if you're on a cardiology ward? Do you want me to grab the ECGs? Or do you want me to look at the OBS overnight to see anyone who was septic overnight, spiking, whatever? If there's anything that happened wrong overnight, do you want me to go through it all and flag it up for you and the consultant at the ward round? You're now making yourself sort of a part of the team, right? So yeah, so you just following sheepingly along is a waste of time. You actively doing a job on the ward round is actually excellent. So what you might do is you might say to the consultant or the F1, F2 doctor, do you want me to, whilst you're doing the ward round, say that it's not a consultant-led ward round. You could say to the registrar and the F2, do you want me to examine the patient? For every patient that we see, I can just quickly listen to their chest and I can give you my findings. What you'll find is that you'll do the exam. They might ask you extra questions. Did you hear the crackles on the right or left, on the bases, both bases? Are you sure you heard dual heart sounds with no murmurs? The registrar might know there is a murmur there, and you start to learn like that. So that might be a very useful way to do that. So yeah, pick up an active job on the ward round. Another thing you can do is ask questions in the ward round. If you notice that the doctors on the team are very pro-education, it is a gold mine for you. Sit there. Do you remember who are our Margate teachers? I forgot. There was Dr. Rudra, and there was
Iona, Lona or something, Laura or something. The F1 that was there at the time.
I forgot her name. I forgot. But anyways, she used to bring out all the ECGs and say, she used to know the abnormalities that were on there. And she'd say, just interpret that for me. And we'd be like, well, it's this, that, and the other. And you'd miss it. And then she'd show you what you missed. You don't forget those things because that's the hypercorrection effect, right? You get things wrong, you remember it more strongly. So that's what I think about the ward round. What about you? What do you think?
Yeah, I completely agree. I think the things we did wrong was we did it in a very passive way. We just went from one patient to another patient. We didn't even know anything about that patient. We didn't think why they came into hospital. What was even the presenting complaint? You're literally there and you're getting glimpses of the ward round. Whereas the proactive thing to do is, the way I see it is, try to do the whole ward round process. So it's learn how to document, right? Learn how to document, or what's good documentation as a junior doctor, and practice doing it, right? So you can be like, okay, you're seeing this patient. Do you want me to prepare the notes for the second patient? And these are things I've done, and I've encouraged medical students to do it, right? And it's had good effect. So learn how to document, prepare notes for the next patient. Like you said, is, all right, these are the obs. Do you want me to read them out to you? And these are flagged, and what can they indicate? Or it's like, this is the ECG, this is the chest x-ray, and then you can kind of guide those to the doctor preparing the notes. You can examine patients. You can kind of ask questions. Okay, why are you doing this investigations? Why are you doing this? So every ward round has many little aspects, and you can kind of take one of those each day and focus on that. Maybe one day you do documentation, one day you do observations and whatnot.
Exactly. I think what's important to understand is a lot of students will look at this, right, and listen to you and me sitting here and say, some of the doctors don't seem keen on teaching us, or the consultant's not on it, or something like that. But you have to understand, right, us doctors, we read the room very quickly, right? You can tell a student who's on it and who's not on it, who wants to do it, who doesn't want to do it. And we'll just cater to that, right? Because if you're not on it, if you don't want to do the vitals, if you don't want to read the ECGs, if you don't want to examine the patient, we're not going to force you to do it, because that's also not what you want, right? So we'll just leave you to it. You can just shadow us and just watch us. But you have those students who are keen, who are eager, who want to make themselves of use, right? So for example, we'll do a ward round, you'll see a patient and the patient has a job to do. Say for example, insert a cannula and get a set of bloods out. Whilst moving on to the next patient, student turns around and says, do you want me to just do that job for you? That's a job I can actually do. Suddenly you're part of the team, and you'll find that the doctors, the consultants, the registrars will reciprocate that energy, right? So you say, can I do that job? Can I do that? Suddenly they're also like, let me also teach you about this, that, and the other. Let me tell you why we've chosen to do that. So anyone who says they're not on it, they don't want to teach me, actually you have to look at, are you on it? Are you displaying that energy, that enthusiasm? Because we often reciprocate that. Obviously, some aren't on it. Some are stressed. You have to remember, sometimes you've got a 70 patient ward round. It's a weekend or it's a Friday and you're preparing for the weekend and it's a little bit difficult. But again, you can make yourself useful to the team. What do you think about that?
No, I agree. And I think you're right. It's very often you can easily tell, are they here for a sign-off? Are they here just spend some time and go off? Or are they here to actively learn? And you're right. You feed off their energy. Yeah. Like if they're excited, if they want to learn, and then we all, as doctors, right? And it's the same thing with Peerr. Like we all love teaching. We all love being educators and kind of helping the next cohort, next generation of doctors. So when I see an on-it medical student, I'm like, yeah, this and this. And I get excited. I'm like, okay, these are the things you need to know. I'll tell you the tricks to being a good F1. So you're right. If you come with the energy of you're on it, you're here to learn, and you can genuinely help and do the little things, and it does help, then most often than not, the energy will be reciprocated.
Absolutely. All right, so moving on now. One of the best ways to learn in a hospital setting, in a clinic setting, right, in a clinical setting, is to actually clerk a patient. People don't really, not everyone understands what that means really. Even I didn't actually. So what does it mean to actually clerk a patient? How would you do it as a student for maximum learning?
So clerking a patient generally is essentially all the stuff you learn in medical school. It's, let's say a new patient comes in, or this is a new patient for your team, and you clerk them. So in essence, it's doing the history which you learn, why they came in, what are they presenting complaint, what's the history of the presenting complaint. It involves the examination of the patient. So it's as if clerking is the same as saying, this is a new patient, figure out why they're in hospital, what's happening, what's wrong, and that process, right? Yeah. And junior doctors do it all the time. It's kind of bread and butter. But as a medical student, you're right. They say, we're going to clerk a patient. What does it actually mean? So when you clerk a patient, I think it's the one time where everything kind of comes together. So it's an opportunity for you to take a history. It's an opportunity for you to examine a patient. It's an opportunity for you to spot certain signs and symptoms. It allows you to kind of take that information and come up with a list of differential diagnosis. And off the back of that, you can then think, okay, what are the investigations I'm going to do to rule certain differentials in, rule certain differentials out? And these are fresh patients, right? They may not have been seen by a doctor. They may have been seen in emergency assessment, but they haven't been seen by the medical team or surgical team, right? So we did it. And I think one of the things I'm grateful that we did was when it was cardiology time, we literally banged out loads of cardio history, loads of cardio examinations. We didn't do cardiology, then a bit of respiratory. We did cardio exams, and it became like the back of our hands, right? And when I became an F1, it came natural to me. Even during a neurology exam, which is quite, overwhelming and nerve-wracking, because we've done it so many times, it felt natural for me to do those type of examinations. So what are the benefits of doing that? So we talked about the things you can do, but how does it help?
So yeah, just before the benefits now. So some people might say, oh, I'm not in an A&E setting or a GP setting to see a fresh new patient to clerk in, right? But this is a hack to it, right? When you want to see a patient on the wards, be it an obs and gynae ward, be it a neurology ward, be it an acute medical ward, ask the doctor who's an interesting patient to see, right? Don't tell me the diagnosis of what you're managing for. And go and see the patient, start from scratch. Ask the patient, what made you come to hospital? And take the full history, right? And then what you should do is, like you said, after the differentials, after thinking about, okay, how would I manage this patient? Go and ask the doctor and see, what did A&E do? Because most patients come through an A&E pathway. Then go and see, okay, what was the treatment pathway? What did the consultant do? And then you can start to see, oh, why did I think this was a pneumonia when actually it was an effusion or a pneumothorax or something like that. So you can start to work your way around why you was wrong and why you was right. Some of the benefits of why clerking patients is good. So number one, you said it becomes second nature. That's important. So you'll find that a lot of doctors, after some experience, right, you're, especially in A&E, right, you're doing multi-system examinations and it's just flowing. You're not really having to think about, okay, cranial nerve 1, cranial nerve 2, 3, 4. Let me auscultate the chest, think about the bases. Let me check for leg length discrepancy. You naturally know, patient came in with this, I need to examine all of these systems, and it's just second nature doing that, and that's really important. And also, not having to think about the next step of your exam or the next question you're going to ask is important for you to be aware of, to pick up positive and negative symptoms, right? If you're thinking always, what's the next cranial nerve to examine, you're not going to pick up the abnormality where the tone is abnormal or they've got hyper or hyporeflexia. So it's important to become aware. The other benefit of clerking in patients is just general experience, pattern recognition. Medicine is a lot about pattern recognition. People come in the same, whether it's in this country, in another city. A heart attack comes in very similarly. Pneumothoraxes come in very similarly. Yes, you have the red herrings and the rare cases, but most of them, they come in very similarly. You need to be able to recognize that. Medical school is so long, right? It's such a long period of time. You just want to come out competent, comfortable. So we have to reduce this whole by F1. F1 is learning by the fire, right? And I think we just need to go back and see what we're doing wrong in medical school for us to learn by the fire in F1, right? Maybe we should start tweaking this. And I guess sharing our experiences with the juniors is a way where they don't have to go through what we all go through in F1. We have to question why do we have to go through all of that as an F1, right? And it's probably because we're not making the most of the clinical years. What do you think? Anything else to add to that?
No, I agree. And I think to kind of finish the clerking thing, it's feedback to the junior doctor, the F1. And then they will fill in the gaps. They will fill in, these are the examination findings, these are the history, these are what we did, these are what we're doing, this is the plan moving forward. And I think kind of feeding it back to the junior doctor is important. And always get feedback. I think the most important thing is we as humans and as individuals, we learn from feedback. And we did that a lot, actually. Like, we did it and then we're like, okay, how do we improve? What can we do? And then we're like, okay, you need to ask this question, or you forgot to ask about this. And then you remember that for the next patient you see. So yeah, that's clerking a patient is a very good way to get a very generic exposure.
So yeah, just to reiterate, you've actually summarized it very well. Clerking can be useless though without feedback. You just doing it and walking off into the sunset, waste of time. You need to know where you're wrong, where you're right. And the best thing to do is either have a mate watch you, because they're objectively just watching you. If a mate's not watching you, make sure you're going back to the doctor and saying, this is what I did, this is what I thought, am I right, am I wrong? And they'll start to teach you. All right, the next thing we want to talk about is, so investigations is a very important part of being a doctor, right? Whether you're in A&E, whether you're on the acute medical ward, whatever ward you're on, you're going to be ordering investigations. There's bedside investigations, the ECGs, the urine dips, all of that jazz. And then there's other investigations, the scans, the bloods, the highly specialized investigations you can do. Why is it important as a medical student to start getting a glimpse of these various things and then think about interpreting them, or practice that even?
So it comes down to the same thing. When you graduate, when you are an F1, interpreting investigations are part of your job role. It's part of your role as a doctor. And I think the last thing you want to do is, the first time you see an ECG or an X-ray is when you're a real doctor, right? Without the safety net of your team. So I think when it comes to investigations, the hack here is to focus on the key investigations that you know you're going to be seeing for pretty much every patient. And that's the ECG, and more often than not, the chest X-ray and abdominal X-ray, right? Yeah. You don't need to start learning CT heads and MRI spines and lumbar X-rays and spinal X-rays, right? Because the exposure and the likelihood of you seeing them is very low compared to ECGs, right? And like you said, medicine is a lot of pattern recognition. So think about the medical student who makes it a habit to learn and review ECGs from third year and graduates in F1 and has seen hundreds, if not thousands of ECGs, compared to the guy that has only seen a handful and then on F1 is starting to see loads of these ECGs. Naturally, who's going to be better at it? Who's going to be better at picking up those patterns?
Exactly. Putting in the reps makes you better, isn't it? On the front of X-rays, ECGs and things like that, it's very important also. Why? Because you might be calling the shots when you're on F1. So there's been loads of cases, right, as an F1 where certain things have been missed on a chest X-ray, on an ECG. And it's because you are actually expected to interpret those things, right? You're not expected to interpret an MRI spine, but a chest X-ray you are. You are expected to pick up a STEMI, an N-STEMI, whatever's going on with a patient, and the investigations are those bedside ones. So you're right, you might be calling the shots, so it's very important you're actually quite good at it. And like you said, putting in the reps, it makes you good at it. You can pick up the pathologies, you can start to action it. There have been cases where, for example, pneumothoraces have been missed, or a chest X-ray was reviewed and there actually was a pneumoperitoneum sign, right? And the patient actually has an acute abdomen, has perforated. You should be able to pick that up, because that now suddenly becomes an acute case. Referrals are needed to be made. That patient needs to go to theatre. So yeah, just putting in the reps in terms of investigating, asking for feedback, of course, that's very important. Look at the ECG, try and interpret it, and then say, have I got it right, have I got it wrong? Anything else?
So one side of things that is worth learning is ECGs and X-rays. And this is when you're super smart. It's when you do the ward run in the morning, most often than not, you'll be requesting bloods. And those bloods should be available later in the day. So what you can do is sit with a doctor and basically go through the blood test results that you requested in the morning. And you might have even helped bleed the patient. You may have even helped send it off to the labs or hand delivered it. And blood is another important thing. Yeah. Patients get blood very regularly. And I think that the key thing here is familiarizing yourself with all of these things and being comfortable with it, being able to interpret it. And you can sit with the doctor and be like, okay, these are the white cells, these are the CRP. Is it getting worse? Is it improving? Do we need to escalate the antibiotics? So on and so forth. So for me, what I didn't do enough and I should have done was interpreting bloods. Obviously, you pick it up while you're a junior doctor, but think of how easy it would have been if we knew what we were walking into.
Exactly. Bloods is probably the single most investigation that will help you manage a patient, right? Exactly. Patient comes in epigastric pain, they're tender there, you do a lipase is 10,000, pancreatitis, you've got your diagnosis. So yeah, definitely. And bloods is all about pattern recognition, right? White cell count, see what the CRP is doing, are they both going up? Having a look at the LFT patterns tells you what sort of condition it is with regards to the liver and pancreas. So it's a lot of pattern recognition. The next thing that you touched on as well already, which is a useful thing to do when you're in the clinical placement, is practicing clinical skills, especially things that you're supposed to do on a day-to-day basis as an F1 doctor. So number one is taking bloods, putting in cannulas, anything else that you can think of?
So I think you don't do this regularly, but it does happen, is ABGs. I think it's a bit difficult as a medical student, and patients may not like it, or junior doctors may feel uncomfortable allowing you to do an ABG. But I think the two things that are worth doing that are easily done, and there's always loads of opportunities, are taking bloods and putting cannulas in. And they're super helpful to a busy junior doctor on a busy ward. Exactly. And like you said, it's your bread and butter, right?
Yeah, exactly. So you'd be very useful actually if you were to go into a ward and say, I want to practice cannulating. Have you got anyone that you want cannulate? Because the junior doctor will be like, yeah, I actually need some help on this. Why don't you cannulate them and I'll go cannulate them? Or you could ask the junior doctor to say, can you supervise me? Can you show me your technique? Because I'm not so good at it. You don't want to be the F1 doctor, right? When you've got the job, there's no one to help you around you at the time, and you're like, I need to cannulate this patient, or take bloods. So yeah, and then there's the other skills, right? NG tubes, catheters. There's those skills. They're often a requirement at medical school, to be honest. So you have to do it. But the best thing to do is get feedback and someone to teach you the tricks of the trade. For example, vascular patient, oncology patients who are incredibly difficult to cannulate. You want to know the tips like let the hand hang, you can use warm water, all of those tricks that help you cannulate. You want to know that. So that's simple, really. You should be getting involved on those skills. And then finally, we're talking about, this is really useful to know, which is just to shadow other MDT members, right? MDT members, the pharmacist, the physiotherapist, the OT team. Why is it important to shadow them?
I think, so there's a big emphasis about the importance of the MDT, the wider healthcare professional team in the management of a patient, right? But you never really get the opportunity to go spend time with them. You kind of know about their existence, but you never really know what they actually do. Only when you're in F1, F2, you then realize, okay, these are people you're directly working with. You then start to learn what they do. Really true. I never know what, I heard OTPT, but I never even knew what the term meant. I thought it was the same thing. Only till I worked in Jerry's or Frailty, then you realize, okay, this is the role of a PT, this is the role of an OT, and then, okay, pharmacists, these are the things they do. And once I knew what pharmacists are really good at, what they can help you, anytime I had an issue, rather than faffing around and trying to figure it out, I went straight to the pharmacist, right? And that's only once I knew their role. Yeah, exactly. And I learned that late.
Yeah, no. That's absolutely it. You have to know what they do, because you can also work as a team better. You just trying to faff around and say, is this patient safe to go home? I'm worried about their mobility. You can just ask the physiotherapist, do you mind helping me assess? Or can you assess this patient's mobility? Do you think they're safe to go home? So you understanding what different team members do is an important tool to each other. They can also ask you, Abdul, can you do this for us? Or this is what we felt about the mobility. Are you concerned about them medically? Because if not, we're probably good to let them go home. So working as a team. The other thing is, as an F1, you might be in a room So after the ward round, you're in a room with the whole team and you're supposed to start feeding back. So everyone knows what you're doing and what each other's doing. If you sit there and you don't know who's doing what exactly are you feeding back to? What are you going to tell who? So it's important to know what people do so you can work as a team. That's it really. That's 5 things that we've covered to make clinical placement very useful. So the ward round, getting involved, clerking in patients, learning and reviewing investigations, practicing clinical skills, and shadowing other MDT members. Have you got anything else to cover here?
No. I think that's a good base when it comes to making the most out of your clinical placement. Yeah. And I think the key thing is you don't need to stay there for the whole day. You don't need to stay there and do every little bit, right? Be very strategic. Use your time efficiently and wisely. And I think the key thing, and you said it in the beginning, is know exactly why you are going in and what you want to achieve, and hold yourself accountable. And I think the advantage is they have clinical pairs and stuff like that. Yeah. So that's a very good way of doing it. But yeah, don't be passive. Have an active mindset when it comes to placements.
So there you have it. We've covered the things that you can do to make clinical placement useful. If you've got any more questions or if you've got any more suggestions, drop them in the comments below. And otherwise, we'll see you next week.